Let's get straight into the clinical decision logic for severe brain injury and ICU management for your Step 2 CK exam. In this explainer, we're covering TBI and coma assessment, brain death clinical diagnosis, apnea and ancillary testing, organ donation pathways, donor ICU management, and post-intensive care syndrome.
Section 1, TBI and coma assessment, focusing on the initial evaluation.
Your baseline is established right away with the Glasgow Coma Scale. You're scoring eye-opening out of 4, verbal response out of 5, and motor response out of 6. Remember the classic rule: a score of 8 or less officially defines a comatose state, which means you need to secure that airway with intubation immediately. Before you even think about advanced diagnostics, you've got to stabilize the patient. Maintain that cerebral perfusion pressure using fluids or vasopressors. Bring down the intracranial pressure using head elevations, sedation, and osmotic therapies like hypertonic saline or mannitol. You also have to prevent secondary injuries, so you'll utilize tranexamic acid within 3 hours, prevent seizures, and strictly control their glucose and core body temperature.
Moving to Section 2, the clinical diagnosis of brain death and differentiating death.
You have to clearly differentiate cardiac death from brain death. Cardiac death presents with irreversible electrical and mechanical asystole. Apnea is universal here, so you don't need any formal testing. Brain death, on the other hand, is an irreversible coma with a beating heart. Because mechanical support is literally breathing for the patient, you have to formally prove irreversible brain and brainstem failure using apnea testing. Diagnosing brain death requires strict prerequisites. First, you need clinical or imaging proof of a devastating CNS event. Second, exclude confounders. That means no sedatives, paralytics, severe electrolyte derangements, or intoxication. Third, the patient has to be warm and perfusing. Core temperature must be above 36 degrees Celsius and systolic blood pressure greater than 100. Only when those are met do you proceed to the neurologic exam. The clinical exam must show a complete absence of brainstem-mediated reflexes. We're looking at absent pupillary light responses, absent corneal reflexes, no oculocephalic or oculovestibular response to cold caloric testing, an absent jaw jerk, and absolutely zero cough or gag reflex during deep tracheal suctioning. Pay close attention because this is a classic exam trap. Intact spinal reflexes do not exclude brain death. Movements that originate purely from the spinal cord, like deep tendon reflexes or triple flexion, might actually still be intact. That's because the spinal cord can function totally independently of a deceased brain and brainstem. Section 3. Apnea and ancillary testing for confirming the diagnosis. Diagnosis requires confirming the loss of the respiratory drive via the apnea test. However, if the apnea test can't be completed safely, you have to pivot to objective ancillary testing. The apnea test proves the failure of the brainstem's respiratory center. You pre-oxygenate the patient, disconnect them from the ventilator, and observe. A positive result confirming brain death is defined as absolutely no spontaneous respirations for 8 to 10 minutes, paired with the arterial carbon dioxide climbing above 60 and the arterial pH dropping below 7.28. What if severe facial trauma obscures cranial nerve testing, or the patient still has paralytics on board? That's when you use objective ancillary tests. This includes an EEG showing a flat isoelectric line, or documentation of absent cerebral blood flow using a CT angiogram or transcranial Doppler. Clinically and legally, brain death is legal death. Mechanical life support may be withdrawn once brain death is confirmed, and you actually do not require family permission to do so. Of course, if a severe dispute arises regarding the withdrawal of care, standard practice is to consult the hospital ethics committee. Section 4. Organ donation pathways and next steps. You need to understand this distinction. Donation after brain death occurs while the legally deceased donor is maintained on full ICU support. Organs remain fully perfused right up until procurement. Donation after cardiac death is for patients who don't meet brain death criteria. Care is withdrawn in the operating room, and procurement only proceeds after natural expiration and an observation period to ensure irreversibility. Discussions about organ donation logistics and consent are handled by an independent organ procurement organization. To prevent any conflict of interest, the primary ICU medical team does not spearhead donation discussions with the family. Section 5. Donor ICU management and preserving viability. Following brain death, the clinical goal shifts entirely to organ preservation, and normal physiology basically goes haywire.
Loss of pituitary function causes central diabetes insipidus, requiring IV fluids and desmopressin. The loss of sympathetic tone causes profound systemic hypotension, requiring pressor support. And the loss of hypothalamic temperature regulation results in severe hypothermia, which requires active external warming. Section 6. Post-intensive care syndrome and survivorship.
For the patients who survive critical illness, post-intensive care syndrome is a major risk. It's a triad of functional decline driven by CNS hypoxia, neuroinflammation, and metabolic disruption linked directly to prolonged mechanical ventilation and ICU delirium. It manifests with psychiatric issues like major depression and PTSD, neurocognitive deficits in memory and executive function, and severe physical debility. You actively work to prevent this using ICU liberation protocols. This means daily sedation holidays and spontaneous breathing trials to accelerate ventilator weaning. It also requires early physical therapy, minimizing deliriogenic medications, normalizing the sleep-wake cycle, and getting rid of unnecessary lines and catheters. When setting goals of care, you have to give patients and families realistic expectations. More than 50% of patients with post-intensive care syndrome experience major depression and decreased mobility. The stark reality is that the majority will require ongoing home care and are completely unable to return to work.